All right, welcome back to the YouTube channel. I'm Dr. Edward Rubin, board certified in pain management and anesthesiology. And today we're going to be talking about chronic knee pain and a specific treatment that us pain management specialists do for chronic knee pain, and that's called a genicular nerve ablation. So to give you a little overview of the knee, there are quite a few structures here that could be the source of knee pain, although typically it's the bone and arthritis. You have tendons, you have ligaments, you have nerves that can be the source of the pain. In this particular technique, we are blocking the nerves that go to the knee joint. The analogy being similar to if you had a toothache and you knocked out the nerve to the tooth, you wouldn't feel your toothache. So along the same lines with this procedure, it's a two-step process where step one involves blocking the nerves to the knee for diagnostic reasons. And then step two is if a patient does well with the block, then we would proceed with the radiofrequency ablation. So the first common question is like, where does this fall in on the spectrum of treatments for the knee? Well, I would put this as a third or fourth line treatment. Typically, before you get to something like this, you've tried physical therapy, you've tried cortisone injections into the knee joint, you might have tried the supplement injections, the hyaluronic acids and gel shots and things of that nature. So typically by the time somebody gets to me with knee pain, we've exhausted those other options before I would go on to a procedure like this. But the thought process is that if you can knock out the nerve supply to the knee, then that signal is not getting to the brain and therefore you don't feel it. So it's not fixing anything, and I'm very clear with patients when we do this procedure, this is palliative. This is just alleviating your pain. It's not really treating the knee. What is nice about it is it's a minimally invasive procedure. So if you're someone that can't have a knee surgery for any number of reasons, then this type of procedure would be a good option to try and put off having a knee replacement or to treat somebody who is either too sick or, for whatever reason, the surgeon feels that they can't safely operate on them for other medical issues. One point I will throw in here, though, is this can also be done after a knee replacement. And those of us in pain management know that our surgical colleagues usually do an excellent job with their knee replacement surgeries, but there are a percentage of people out there who still have knee pain after a knee replacement, and this is still an option even for somebody who's had a knee replacement. So typically there's three nerves that we block for this procedure. It's done on an outpatient basis. I do it under x-ray guidance. So it's a pretty quick and easy several minute procedure. But you want to knock out the nerves diagnostically, send the patient home with a pain diary to see if they got relief, and then decide from there, whether or not to proceed. In terms of indications, I mean, we pretty much laid it out, but typically it's going to be your osteoarthritic patients, and for whatever reason, they're not a candidate for surgery, or they really just want to put off having the surgery. As I mentioned, this can be done on patients who've had knee replacements already. So just because you've had a knee replacement, if you're still having pain, then you are a candidate for this. Once we've done the diagnostic block and we've determined that the patient had success with it, now that success could be a short-term success, and I try and tell patients, if I do a diagnostic block and you're super duper for 8 hours, that's important for me to know, because sometimes patients will come back 2 weeks later, it didn't work. It only lasted for 8 hours. Well, this was a diagnostic block. So that 8 hours of relief proves to me that you are a candidate. So that's why I typically ask patients to fill out a diary at home so that snapshot of the day of the procedure is a little fresher in their heads. So preparation for this procedure is pretty simple. It's an outpatient procedure. I do them under x-ray guidance. Obviously, you don't want to have any active infections going on. Blood thinners, sometimes I'll let patients continue blood thinner medication. In terms of fasting, if you're doing it awake with just local anesthesia, you don't have to fast. The actual procedure itself is literally 5 minutes to do the whole procedure. I do them laying down, I do them under x-ray. You can be sedated for the procedure. Could also easily be done awake if you prefer. So I've done it both ways. You can do both sides at the same time. So you can have bilateral knee blocks done, and that's what a typical x-ray guided knee block looks like. We obviously do put local anesthetic in before we do the shots, but it's 3 needles targeting those nerves. That's the step 1 procedure, and then on a separate day, you would come back for the step 2, which would be the radiofrequency ablation. Post-operatively, you're not limited. You can walk around after the procedure. Only restrictions are not to submerge it in water. You can drive, but not if you received anesthetic, meaning if you had general anesthesia or sedation, rather, you wouldn't want to drive. After the procedure, you could have typical side effects from being sedated, and you would just basically treat that the same way you would as any other outpatient procedure. You can ice it afterwards. You can take pain medication if needed, but typically the pain gets better. The radiofrequency ablation part of the procedure is not really much more involved. We do nerve testing to really pinpoint the nerve, so you do have to understand that if you get sedated for the ablation, that you would want to, have